Hi everyone, this is Professor Austin. I wanted to provide some more information to you guys regarding how to code a medical record or just things that you should remember when trying to assign the codes from a medical record. I know for the most of you guys, you've had your coding classes and this is a refresher for you all. So hopefully this document that I created will help spark some things when you're looking in the medical record and you're trying to assign some codes. So I want to quickly point out some areas that you should review and that you should remember, starting with your face sheet or your admission summary sheet. On that particular sheet or document, basically you will see a lot of patient demographics, such as the patient name, gender, the date admitted, discharge date, so forth and so on. Your discharge summary is the most reliable part of the medical record. It supports the principal diagnosis that the physician determines after study. So remember, when you guys are looking in the medical record, as you can see now, we have this course is made up of coding, and you guys will be coding from medical records. Please remember that the discharge summary is one of the most important documents that you need to read when trying to code a chart. The discharge summary is a synopsis, okay? It gives a synopsis of the patient's stay. So if you're trying to find out, what's the principal diagnosis, did the patient have any chronic conditions, any acute conditions that occurred, was there any therapy, what type of tests were run, any labs, things like that, you will be able to find this type of information listed on the discharge summary. So this is basically where you want to begin. The face sheet will give you an idea. I like that it gives you an idea of why the patient is here. Most of the time you'll see the admissions diagnosis and it'll be very vague. It'll say something like, chest pain, high blood pressure, or something like that. And then of course, once you guys have, started to read the medical record, you'll be able to find out or connect the pieces to see what actually took place. Moving forward to the H&P, the history and physical. Review the H&P to help determine the chief complaint. Also, the history portion is good for picking up any chronic conditions that comply with the UHDDS rules. So, for instance, there may be a condition that is affecting the patient's care, a disease that is controlled with long-term use of medication. This is something that you will want to pick up. So these are those chronic conditions or something that's currently being treated. You want to be able to pick those up. Please keep in mind, however, the H&P is very detailed, especially the history portion. It will have past information about the patient's health. Please keep in mind that you do not want to pick up things that have no bearing on the patient's current care at that moment. Meaning that in the history you may see patient, had a fractured rib 15 years ago. If that has nothing to do with what's currently going on, the management of the patient's care, then we're not going to pick it up. Now, however, if you're reading a medical record and you notice that 2 years ago the patient had a mastectomy of the right breast, and you know that today the patient is currently in here because a lump was found in the left breast, then yes, we're going to pick it up because now this is showing a connection. Now we're showing that this patient has a history of breast cancer, and we need to code those. Those actually go together. So those are some examples that you want to keep in mind. Your anesthesiology report. Remember that the anesthesiologists are treating physicians, meaning that, when we're coding from the medical record, we're not picking up anything that the nurses have written down. We don't honor their documentation. We can read it, just to kind of get a better understanding. However, we can't code anything that the nurses have, documented in the medical records, okay? So with that being said, however, if the codes that the anesthesiologist has assigned conflicts with the attending physician, you must query the physician for further clarification. So meaning whatever that the anesthesiologist has written down, we can code that. This is someone, because he's a treating physician, we can code what has been documented. However, again, if it conflicts with the attending's documentation, then we need to query the physician. Okay? That being said, coders can safely code from the anesthesiology report as long as it does not conflict with the attending has documented. Remember, documentation is the key. Okay? Consultation reports. Coders can code from the consultation reports as long as it does not conflict with the attending's documentation. So in any event, if you have two conflicting diagnoses, query the physician. But because you all are coding from a mock record, meaning that these records are not real, okay, we don't have time, and we're not in the atmosphere where we can query physicians, you will code what the attending has documented. As you note here, in the real world, this will be a situation where you will stop coding the chart and query the physician to receive further clarification as to which diagnosis he or she wants you to code, whether it to be the attending's diagnosis or the consultant's that the attending has to decide. Your operative reports. So, of course, this type of report will only be present in the medical record if a procedure was performed. If you guys have noticed, we're kind of taking it slow with you. So we're starting with our ICD-10-CM codes, meaning you guys are only coding diagnoses this week. Next week, I believe we are moving forward to your PCS, meaning that you will code ICD-10-CM and PCS codes, your diagnoses and your procedures. But I don't want you to pull your hair out looking for an operative report. This will only be in the chart if a procedure was performed. At the top of the report, you will see the preoperative diagnoses and the postoperative diagnosis and the operation performed. So to only code the three without reading the text is incorrect. So you will see, once you've seen the operative report, there's a nice detailed description of what actually took place in the procedure. So what they did, the details, if they found anything, what type of route they took, so forth and so on. So you want to pay attention and read that documentation thoroughly to make sure that you are coding to the highest specificity. Okay, a note here, point of note, depending on the diagnosis for the procedure performed, you may need to refer to your pathology report and the physical examination to correctly code the diagnoses for procedure. So for example, the pathology report will indicate whether a lesion that was removed was benign or malignant. So you guys really have to kind of revert back to your intro to HIM days, when you're learning about the medical record and learning about various reports in it. You really want to revert back to that to see what type of content will be present on each report. Places that you want to avoid in the medical records. Your ancillary reports, and those are like your x-rays, your labs, and diagnostic testings. So for coders, we are to never code on your radiology reports. They can be used as another form of interpretation. Code should only be assigned from the radiology reports unless there is documentation from the physician. So for instance, if the patient fractured their arm and the physician has not listed the specific area, you can view the radiology report to capture the definitive area where the bone was fractured. So for example, fractured rib is what the physician documented, but when you reviewed the radiology report, you noticed that the radiologist noted fractured left fifth rib. So now you have a more definitive diagnosis, and you can use that, okay? So this is the only time that you can use that. As far as your laboratory reports, you can also use those as interpretation, but we cannot code from those as well. As you guys become more used to coding and you get out in the field, you will be able to use that laboratory report to kind of connect the dots. When you're reading the lab reports, for instance, you'll begin to kind of know how to read various levels and things like that. So, for instance, when you're looking at the lab reports and you see that the WBCs, the white blood cells, are elevated, you would know, or you'll begin to know that, okay, that may be an indication of some type of infection that is present in the body, okay? Not that we can code that, however, it's just giving you a heads up. So maybe the patient, if they did like a urinalysis, maybe they found out that the patient has a UTI. So there's how you can kind of connect the dots to let you know, like, okay, well, I saw that the white blood cells were elevated. Possibly there is some type of infection, but we still need for the doctor to document UTI or whatever it is that's going on here. But again, interpretation is always good too. The nursing notes. Coders should never assign codes from the nursing notes. This is another report that can be used for interpretation or clues that may lead to a particular diagnosis. And you guys, the nursing notes, you will love them because they're very detailed, straight to the point. And if you're working in an environment where they're still using paper medical records, you will love them because they have legible handwriting, okay? Working in the EHR field, of course, that may not be an issue anymore because everything is typed, so that's good. But however, their documentation is great. Again, we cannot assign any codes from what they've documented, but we can use that for interpretation. Please remember when assigning the codes, please do not forget to comply with the coding guidelines and coding conventions established by the UHDDS. The definition of the UHDDS will help you figure out your sequencing, principal diagnosis, and principal procedure codes. So you want to think about that. You want to, when you guys are picking out your codes, remember that it should read like a story. Okay, so when you have your principal diagnosis, this is what they came in for after study. Okay, and if you have your principal diagnosis, and as we move forward into this course, you will collate principal procedures. Your principal diagnosis and your principal procedures should correlate with each other, okay? So, for instance, if your principal diagnosis is myocardial infarction, for your principal procedure, I should see something cardio-related. That's what we're saying. It should kind of correlate. So whether that's like a triple bypass surgery or some type of stent or something that's going to, fix this myocardial infarction, whatever it is that they did, those two should mesh. We should not see for your principal procedure, and again, I'm just making things up. We shouldn't see biopsy or cast removal, things like that. So we want to make, even though they may have gotten those things done, and that may be like a secondary secondary procedure that you want to list, that's fine. But you want to make sure that your principal diagnosis correlates to what you have with your principal procedure, okay? And then again, with that sequencing, principal diagnosis is your number one thing to worry about. Secondly, you want to get those chronic conditions in, okay? You can kind of pinpoint those chronic conditions, especially if they're currently being treated for that. Long-term regimens, if the patient is taking medicine for that stuff, you want to pick it up. It's a chronic condition. Also, we can code acute conditions. Things can currently happen during that visitation, whether it's a UTI or a patient may have gotten maybe tachycardia or something like that. So you want to remember that we can also pick up acute conditions as well. So I'm hoping that this quick guide will help you guys to get back on track. I'm going to email you this so that you can have it for your own use. Remember to refer back to it. And as a special tip too, when you guys are coding those medical records, have a scrap sheet of paper out to document things, to jot things down, because you're going to forget as you're reviewing the medical record. It's a lot of content. So jot things down that you would like to code, and then go back and do process of elimination, because we can't code everything. All right? So if you have any more questions, feel free to give me a call or email me. Thank you and have a great day.